Hey guys, it's Dr. Young from Sternal Ophthalmology, and if you are watching this video, it's probably because you are thinking about cataract surgery or you've already scheduled your cataract surgery. So I wanted to give you a little lowdown on kind of what all is involved, what is a cataract, how do we remove it, what happens with the surgery, what restrictions are there after the surgery, what kinds of lens options do you have. There are a lot of different things to discuss, and we'll talk about all these things in the office, but just wanted to give you this as a little primer so that you also have this as a reference if you'd like to watch it again if you have questions. So stay tuned and we'll go over all those things. Okay, so what exactly is a cataract? You know, a lot of times when patients come in and they say, oh, I think I have a cataract, are you going to scrape that off the surface of my eye? It's not in the front of the eye. The cataract is actually sitting right behind the colored part of our eye, the iris. So I just want to show you just on our little model. This is a cross section of the eyeball. Here's the cornea, the clear kind of windshield of the eye. Then the iris is the colored part. And then directly behind the iris is where our lens sits. And that lens has been there as long as we've been alive. It starts out clear, and as we age, it just gets cloudier and cloudier and cloudier until eventually, instead of looking like a nice crystal clear lens that focuses everything, it starts to get kind of yellow and brown and cloudy. And so when that happens, instead of the light coming in through the cornea and through the lens and being focused precisely on the macula, the center part of our retina, which is where we do all of our fine detail vision, those light rays get scattered. And so that's why a lot of folks, you know, their main symptoms that they come in with at the beginning are nighttime driving is starting to get really obnoxious as the headlights are coming towards them. They're seeing all these starbursts and halos and just nothing is crystal clear anymore, because instead of that light being focused properly and all together, all the rays are going all over the place. And so you just can't get that crisp image even with kind of the best possible glasses prescription that we can find for you. And that's when it's time to have cataract surgery. So how do we do it? So cataract surgery, fortunately, is a straightforward procedure that takes me about 10 or 15 minutes. It's done in an outpatient surgical setting. What we do is make 2 small incisions in the cornea that are going to give me access to the cataract, which is sitting behind the iris. We dilate your eye when you come into the surgery center so that I can get that pupil nice and open and then see what I need to see for the cataract. The cataract itself is held in this very, very thin membrane called the capsule. And so the first step to surgery is just opening up that capsule to give me access to the lens. And then we use ultrasound power. It's kind of similar to the technology that your dentists use when they're cleaning your teeth. It's going to go in and break up that lens and do a bunch of little pieces and allow me to then aspirate it out of the eye. Once the cataract is removed, then we do an implant. Everybody gets a lens implant at the time of surgery. The powers differ depending on the optics of your particular eye, and so we'll talk about that a little bit later, how we decide on that power. But once we've decided on that power, then the lens is folded up like a little burrito, so it can fit through that really tiny 2.4 millimeter incision that we make in the cornea. Once it's inside the eye, it's going to unfold. It has these little arms that are called haptics that kind of, look like this. And so as the lens, which is going to be, just a circular lens, unfolds, those haptics are going to unfold as well, and then allow it to be centered in the capsule I was talking about earlier for the rest of time. So once the lens is implanted, it's there for the rest of your life. It doesn't need to be replaced. It doesn't, wear out like a knee replacement. You need a new knee replacement in 10 or 15 years. You never need to redo your cataract surgery. Once it's done, it's a done deal, which is great. Okay, so now we're going to talk about the different lens choices that you have with cataract surgery. This is probably the most confusing aspect of the surgery itself, is picking which type of lens. So I always like to break it down simply into 2 different categories. So there's one group of lenses called a monofocal lens. That lens has the same power in it all the way through, and we can choose one focal distance that we want to correct for. Most people are going to choose distance, and then they just throw on their reading glasses. They can get excellent vision at distance with no glasses, and then for reading, they have to throw on their glasses. But one thing that's important to understand about that, a lot of people say, oh, I'm fine with reading glasses. But what that means is every near task that you do is going to require glasses, not just reading. So, you need to look at your watch, or you look at your phone, or sometimes even the dash in your car. So that's a great choice for people if they're okay with having to put glasses on for all of those near activities. Patients who choose a monofocal lens can also just choose to go back to a regular progressive in their glasses so that they don't have to do the on and off with the readers. And that's what a lot of folks will do as well. Those lenses are excellent. You'll see beautifully. They do a great job. They are considered to be part of the surgery by your insurance, so there's no additional cost for a monofocal lens. So that's one type of option. Okay, the second category of lenses are called advanced technology lenses or premium lenses. And these are lenses that have a bunch of different kind of corrections in them that are really aiming to get people out of glasses as much as possible. So from these, we've got the lenses called torics, which are going to correct astigmatism. So astigmatism is a problem where the surface of the cornea is irregular. And because the surface of the cornea is irregular, the light beams are focused in two places instead of one place. And so the toric lenses allow us to focus those light rays on one focal point as they should be. Toric lenses are not useful for everybody. You have to have a particular, kind of corneal topography. We'll talk about topography in a second, but when we do the measurements. But toric lenses are something that can be used to correct astigmatism. The other type of lens is called a multifocal lens. There are lots of different brands of multifocals, lots of different makers, but the underlying process is the same, and that is that these lenses have, instead of one power throughout the entire lens, they have concentric rings of power in the lens. And so when we implant these in the eye, and then you're looking through these lenses, your brain is going to choose which ring of power it wants to use for any particular thing, whether you're looking at something for distance or at your computer, which we call intermediate, or if you're looking at something up close. Okay, so you've decided to have cataract surgery. Kind of what all are the steps that are going to happen? You call the office, you say, I'm ready to schedule. So first of all, there are a lot of appointments. So just kind of settle into the fact that you're going to get really tired of seeing us pretty quickly because there's a lot of pre-op visits and a lot of post-op visits. And that's just because we only have two eyes and they're very important. And we really want to make sure that everything's healing beautifully after your eye surgery. The first step is to schedule your pre-op. So at your pre-op visit, we're going to do a whole series of measurements on the eyes that allow me to calculate the power of the lens implant that I'm going to put in at the time of surgery. In a second, we'll go back to our little diagnostics area and I'll show you some of the different testing that's done at that pre-op. But there is quite a bit of testing done because we want to make sure that your retina is healthy, that we've got a good measurement of your cornea, that we've got a good measurement of the length of your eye. There's a lot that goes into deciding what power of lens to implant at the time of surgery. So that's going to be your pre-op visit. I like all my patients to kind of get the eyes ready for surgery, meaning that we want to get all the bacteria off of the lids and lashes. We want everything to just be in tip-top shape before I'm actually going in and making incisions in the eyeball. So I like all patients starting 2 weeks before surgery to start doing these little lid scrubs. Lid scrubs are found over the counter. We sell them at our office. You can get them at Amazon. You can get them wherever. This particular brand happens to be OcuSoft, but there are a couple of different brands out there. All these do is exactly what they sound like they do. They're going to scrub the lids and lashes and get all the bacteria off of the lids and lashes. So morning and evening, starting 2 weeks before your surgery, you're going to take one of these little towelettes out. They have a little already soapy towelette that you wrap around your finger, close your eye, and scrub back and forth, starting at your eyebrow and going all the way down to this lower rim of your orbit. So the whole eye area, right eye, then left eye, morning and evening, 2 weeks before surgery. That's going to just clean off the lids and really reduce the risk of infection, which is the aim of this whole thing. I also like folks to start using preservative-free artificial tears. This is just one of a million brands of preservative-free artificial tears, but the main thing you want to look for is they should come in these vials. So if they come in a bottle, they're probably not preservative-free. And in and around the time of surgery, I prefer preservative-free tears or preservative-free drops in general because they're going to be less irritating to the eyes. A lot of drops that come in bottles have preservatives, and that's why they can stay on the shelf for years and years. Those are not the ones that we want to be using around this time. So I ask my patients to start using these about 2 to 3 times a day, starting several weeks before surgery, really as soon as you can, leading up to your pre-op, because the more lubricated the eye is, the better measurements we're going to get. If your eye is very dry when we're trying to get these measurements for your lens calculations, we're not going to get accurate measurements. And then it doesn't matter, how good your surgery is. If those measurements are off, we're not going to get a good result. And similarly, just from a healing standpoint, you don't want the eye to be super dry going into surgery because it's going to take longer to heal. It's going to be more uncomfortable. So lid scrubs twice a day, preservative-free tears 2 to 3 times a day, starting 2 weeks before surgery, bare bones minimum. All right, so here we are in the diagnostic testing room. So when you come for your pre-op, there's actually quite a few different tests that we're going to do. The first one is called the IOL master. This is probably the most important one. It's going to measure the length of your eye, the curvature of your cornea, and then plugging that into a bunch of formulas are then going to allow me to choose the power of the lens implant that we're going to use. When you come for your pre-op, we're also going to be checking you with a scan called an OCT. That's these machines over here. The OCT is going to get a cross-section through your retina to make sure that there isn't any underlying pathology that we need to know about before we go forward with cataract surgery. This is the topographer. The topographer is another really important part of the testing because it's going to show me exactly what the surface of your cornea looks like. That's going to let us know how much astigmatism is in the cornea, where that astigmatism is located, and then we can figure out how we're going to align that lens implant once it's implanted based off of that topography. This is also one of the reasons it's really important to do the tears and keep the eyes lubricated like I was talking about earlier, because if the eyes are really dry, we cannot get a good measurement on this. And then again, we are basing all of our calculations based on these measurements, and if they're wrong, then the lens implant can be the wrong power. So really crucial to make sure you do all those steps we were talking about before to make sure the eyes are perfectly lubed. The last and final thing we do at your pre-op is something called an A-scan. We use a machine that this is probably the only part that's a little strange because you're going to be lying down flat in our minor surgery room, and one of the technicians will be putting a little probe on the surface of the eye. There's some water that flows over the surface of the eye. This is basically kind of an older version of the IOL master, but I still like to use it because it serves as a backup to the measurements that we get with the IOL master. And so that's just kind of a nice reassurance that we have the numbers that we want. So when you come, plan on having a bunch of tests. It's all part of the process to make sure you have the best possible outcome. Okay, so you're all prepped and ready now. You're arriving to surgery on your surgery day. You're going to come to your surgery time, which will be about an hour before your actual scheduled surgery at our surgery center. All of the doctors here at our practice operate at the Methodist Ambulatory Surgery Center, which is just right down the road from the office, very close to where you're used to coming. We'll have you come an hour before your scheduled surgery. The nurses will bring you back to the pre-op area. They'll get your IV started. They'll get your pupil dilated. And then once we go back to the operating room, we're really only there for about 30 minutes or so. Surgery takes about 10 or 15 minutes, and then we watch you in recovery for about 30 minutes. So you can tell your chauffeur, whoever's going to be taking you that day, that it's about 2.5 hours at the surgery center. You absolutely need a driver because you'll be getting anesthesia. We all, use different anesthesiologists, but you'll be getting some good anesthesia that makes you nice and calm. This is not a procedure that requires general anesthesia, so there's no tube down the throat. It's much lower risk, fortunately, because of that. But we do use what's called conscious sedation. If you've ever had a colonoscopy, it's very similar. You'll feel, pretty drowsy, and you sort of snooze through the whole thing. You wake up in recovery, and a lot of my patients say, "When are we starting?" And it's already over. So there's no pain, no discomfort during the surgery at all, which is great. When you wake up in recovery, you're going to have a pair of sunglasses on, and I usually ask my patients to keep those sunglasses on for at least 4 hours after surgery, even indoors, because your pupil's going to be massively dilated, and now instead of this cloudy lens, you have this nice clear lens implant. Everything's going to be super, super bright. The eye tends to be a little more light sensitive for the first week or two anyway, just because of the mild inflammation that our eye will have after surgery. But also, you just kind of have to adapt to the fact that there's a clear lens there instead of a cloudy lens. So you're going to want to wear sunglasses for a while after surgery, and we'll provide some dark ones for you. You will also be going home with a clear plastic shield that you'll tape over the eye at bedtime or anytime you're sleeping for 1 week after surgery. There's no special positioning that you have to do while you're sleeping, and if you sleep on your right side and you had surgery on your right eye, that's okay. We just want to make sure that you have that eye covered so that if you bend over and you have your face kind of in your pillow, that the eye's not going to be getting smushed. So you'll wear that shield at nighttime for 1 week. You do not have to wear a shield or anything in particular during the day. So other restrictions, you do want to kind of lay low for the first week after each eye. And a lot of times we'll do one eye, this week, and the second eye the following week. So for those people, it's going to be 2 weeks total. Those restrictions include no heavy lifting greater than 10 or 15 pounds. A gallon of milk is really kind of a good estimate. If it feels heavier than a gallon of milk, it's probably too heavy. No jumpy, jarry type activity. So anything where you feel like you're bouncing, like jogging, or even simple things like the elliptical. Those sorts of things you're going to want to hold off for a week after each eye as well. The most important thing is no bending. So that's probably the hardest part of the whole deal. Because we just bend over all the time and don't even think about it. So you don't want to be bending where your head is all the way down hanging in a dependent position, because that's going to increase the pressure in the eye, and we don't want that increased pressure on those very freshly healing corneal wounds. So if you need to bend over and pick something up, try to squat, keep your chin up and pick it up that way rather than having the head all the way down. You can still bend over to brush your teeth, to put your shoes on, those sorts of things. That's fine. You just don't want to be, all the way down where you bend over and you kind of feel that pressure in your head. That's what you want to avoid. And that's going to be a week after surgery as well. Otherwise, most people are able to kind of go about their normal routine like they usually would. If people are still working, they'll take a couple days off, but usually people don't have to be down for very long after this surgery. No lens is as good as the lens that we were born with. That's the best lens. So we're trying to mimic our natural lens as much as we can, and technology is getting better and better at that, but it's not perfect. So there are some trade-offs with that. Okay, so pros and cons of each of the different types of lenses. The pros of the monofocal lens are that you're going to have really crisp distance vision. The cons are that you're going to be requiring reading glasses for anything that's up close. Pros of the multifocal lenses are that you're much less dependent on readers. And notice that I say much less dependent, not completely reader-free. The multifocal lenses are very, very light dependent. And so if you're in a really dark room, you're in a restaurant that has dim lighting, it's still going to be pretty challenging to see that small print. And sometimes you have to, get your phone out and put some light on it, or put on a light pair of readers. So I always like to encourage patients, listen, this is going to give you the opportunity to be as independent as possible from glasses, but not necessarily completely glasses free. And that's really important to sort of realize when you're going into this. The other thing that we have to be aware of with the multifocal is that because there are these rings in the lens itself, when you are driving at night or you see any kind of point source of light, especially at the beginning right after surgery, you will actually see those rings of light. And some people see concentric circles, and with some of the lenses, patients describe more of kind of like a spider web pattern where they have lines coming out and then rings around. So, for example, I would never put these lenses in somebody who's like a professional truck driver or something like that. If someone who drives at nighttime for their living, I would never recommend this lens. But for those of us who drive, just home from work or to the grocery store, our night driving is limited, that's an option for you. But it's something that you need to be aware of. There are definitely some nighttime vision issues associated with the multifocal lenses. Okay, so another thing people are frequently asking questions about is, how much am I going to pay for this? Is my insurance going to cover it? Cataract surgery in and of itself is the number one surgery that's covered by Medicare. So it's covered by all insurances if you have reached a point where it's deemed medically necessary. The nuances come in when you're talking about what kind of lens you want. So like we were talking about earlier, if you choose a monofocal lens, that's considered part of the surgery. So that's included in your surgery cost. If you choose a toric or a multifocal toric, those lenses are all considered by insurance to be kind of icing on the cake. So they will pay for your surgery, but they won't pay for the additional charges incurred by those advanced technology lenses. When you come in, we'll go over kind of all of the pricing with that, but those are considered to be kind of an above and beyond insurance coverage. Another thing people frequently have questions about or get kind of confused about is deductibles. So remember that even though the surgery is covered by your insurance, if you haven't met your deductible, you're still going to be required to pay that deductible, whether that's here at our office or more commonly over at the surgery center for their surgery center fee. So we try to estimate these things for you, but again, they're just an estimate. So the only way you can find out for sure is by calling your insurance company and asking them directly. All right, so let's go over some of the risks of cataract surgery. Fortunately, I always tell patients this is truly one of the safest surgeries you can have, which is very reassuring, but no surgery is without risk. So the main things that we watch for with cataract surgery, of course, like any surgery, infection. So the risk of infection in the literature is about 1 in 1,000. I don't actually end up seeing it that frequently in our practice, but that's what we see in the literature. The most important things we can do to prevent infection are the things that we've already talked about. So getting the lids nice and clean with those lid scrubs prior to surgery. We use a betadine scrub during the surgery, which is going to clean the lids, clean the lashes, clean the surface of the eye before we even get started making incisions. And then using your drops afterwards. All of those things are going to decrease your risk of infection. You want to make sure that you're always washing your hands before you put your drops in, and that you're not rubbing or messing with your eyes, especially in the first week or two when those incisions are really kind of starting to heal and are just newly, freshly healed. The warning signs and the things that you would experience if you were having an infection would be very red, very painful eye with a sudden decrease in vision. It's usually not subtle. That typically happens within the first 3 to 5 days if it's going to happen. I always tell my patients, if you are concerned at all after surgery, you call, and that's even on the weekend. There's always somebody available on the weekend, and if you're post-op, you don't want to just kind of tough it out. You want to let us know so we can take a look at you. Fortunately, again, that's extraordinarily rare. If that were to happen, we send you over to the retina doctors. They do an injection of a medication into the eye that helps treat that infection. But again, low risk for calling in that first week or two after surgery, especially. Dry eye can definitely be a little bit worse after cataract surgery, usually for the first 2 to 3 months is what I find. So it's really important to stay on those preservative-free tears regularly. Even after you're off of the prescription drops, you'll still want to continue lubricating the eyes because I do see that the eyes tend to be a little bit drier afterwards. Retinal tears, retinal detachment. That is a risk, again, in the literature, quoted around 1 in 200. I really don't feel like I see it that frequently. I probably see maybe 1 a year, 1 every 2 years, something like that. And I do about 500 cases a year. So I don't see that as frequently in my practice, but that is a possibility. It is definitely a much higher risk in people who are already very nearsighted. So, folks who have a prescription that's say a -5 or a -7 or -9, their eyeball just by definition is much longer than the average shaped eye. And so their retina is stretched out over that larger surface area, and it makes the edges of the retina a little bit thinner and more prone to tear. So, especially in my folks who are very nearsighted, we talk a lot about retinal tears and retinal detachments. Everybody gets a dilated eye exam at their 1-week post-op visit to look precisely for that, to look for retinal tears. If there was a tear, I would send you immediately over to one of my retina colleagues who would perform a laser treatment on that, which would basically just seal down the area around the tear and prevent you from having a retinal detachment. So there's definitely a wonderful treatment that can be done that preserves the vision. We just need to get on it quickly, and that's why we want you to call if you're concerned at all. The symptoms of a retinal tear would be very different from an infection. A tear does not hurt, but it does present typically with flashes of light, like an arc of light off to the side that's split second. A lot of people feel like there was a camera flash or something that went off to the side of them and they realize that's coming from the eye. So repetitive arc-like flashes of light in the periphery, or a showering of a whole bunch of new floaters. So we all have those couple of floaters that, kind of come and go in our vision, look like gray spots. But if all of a sudden it feels like somebody took a pepper shaker in front of your eye and there's just hundreds of little black dots, that's really concerning for a tear. So flashes of light, pepper dot floaters, those are the things you should be calling about immediately. Other risks, at the time of surgery, when we're actually in the eye, that capsule I was talking about earlier, occasionally that capsule is weak or it breaks during the surgery for whatever reason. And then, we have to kind of change course and put in a slightly different lens, sometimes a lens in a different position. And if that were to happen, the inflammation that happens after surgery is, a little bit more robust, and it tends to take a while before things clear up. Fortunately, even if that capsule breaks during surgery, we can usually recover, well, and patients still do remarkably well. So those are kind of the main things that I go over with patients as far as risks. Nothing is perfect, of course, but truly cataract surgery is probably as close to perfect as it gets. In some of the latest studies, 99.7% of people had good outcomes for cataract surgery. So if you have to have surgery, this is a pretty great one to have. Okay, so that is everything you ever wanted to know about cataract surgery and more. Obviously, at your appointment, we'll be here to answer specific questions that you have and anything that wasn't covered here. But hopefully this is just kind of a good outline of what to expect after your surgery, during your surgery, and before your surgery. And we'll see you in clinic.